Thanks so much, everyone, for watching. We've got an epic lineup tonight of speakers. We've got an awesome panel here. Amazing group of functional doctors, technology, activists, for a leap forward in medicine.
You know, our goal is to make it easy for practitioners to learn in community.
This ecosystem that has been set up by the meetup groups, we believe will be the future ecosystem of this evolved primary care network, and it all revolves around you.
Welcome to the Functional Forum. Thanks for joining us in the charge to accelerate the evolution of medicine. Please welcome your host, James Maskell.
Hello, everyone. Welcome to the Functional Forum. It is February, and we are here for a very special Functional Forum on heart health and the endothelium. I'm really excited tonight to have a couple of people on the Functional Forum who have been on before in different capacities, and also a big name from the functional medicine community that has never been on the Functional Forum before. We're going to be talking about heart health and the endothelium. It might be the most important topic in the world right now to really understand how do we facilitate, as practitioners, healthy hearts? How do we keep hearts healthy? How do we reduce cardiometabolic disease of all varieties? And I'm super excited about what we've got coming up tonight. So as ever, this is a live show. And so you can use hashtag Functional Forum on Twitter. I'll be monitoring it. Just to give you an idea of what we've got going on tonight. So we've got a couple of wonderful practitioners. We've got Dr. Kristine Burke, who many of you guys know, which was on this time last year, talking about uric acid in the forum that we did about uric acid. She also happens to be my doctor, and so I'm grateful to have her on. We also have Dr. Michael Twyman on live, who is a cardiologist from the St. Louis area. And a bit later on, he's going to be talking all things endothelium and glycocalyx, and he's an expert in those areas. So if you have questions about the glycocalyx, the endothelium, how to treat it, how to test for it, certainly you can put that on Twitter and get those questions coming in for the second half. Want to say a shout out to all of the communities around the country that are having events. Actually, Dr. Burke, as most of you guys know, is the chapter leader for the Sacramento Folsom event and has been running communities for her local area, which I just happen to live in, for the last, even before the forum started, more than a decade. And so I'd like to welcome them and all the other communities around the country. We got some exciting news coming up with that very soon. And thank you to all of our supporters for their continued support of the evolution of medicine and what we're up to. So the first person I want to bring on here is Dr. Kristine Burke, and I'm just going to stop sharing my screen here for a moment. So Dr. Burke, welcome. Glad to have you. Actually, we're just about to get into your presentation. It's funny, actually, a year on, because this time last year we were talking about uric acid, and I just saw recently that there is a strong correlation between uric acid and heart disease. Here we are a year later talking about it. So, when you're in the business of functional medicine, it's all connected, right?
Yes, it always is all connected.
Well, I'm really grateful to have you here tonight. And the idea for this forum and having you on, I'm super excited to have Mark Houston share a little bit later. But I got my letter from you about that I was, to continue my care, because I've been under your care for over a year. And on that, at the bottom, there was a message saying that you had never had a heart attack in your practice. And, I just feel like if we're going to talk about heart health, we're going to talk about the endothelium, we can get all into the details. But ultimately, what we want is, people being healthy and not having heart attacks. And, you've been doing this a long time. You've had a practice for a long time. It seemed to me that was sort of like a pretty amazing stat. And so I guess, why don't we just start here? I mean, what I'd love for you to share is, sort of a little bit of a presentation about how you run your practice, a little bit about, sort of your background and the way that you're thinking about heart health, because ultimately, if we want to build, I guess the purpose of the evolution of medicine was to help doctors to build practices like yours. And so let's get into that now.
Yeah, so I run the True Health Center for Functional Medicine, and we do primary care from a functional medicine root cause lens. And then we also do functional medicine consultative practice. And in that, my area of particular expertise is in dementia reversal. But I got there through diabetes reversal and cardiovascular disease reversal because, as you mentioned earlier, all of these things affect the health of the brain. So that was kind of how I ended up there. But in our wellness program that we do for our primary care patients, we do an analysis of their vascular health, and we look at their carotid CIMT and a variety of vascular inflammatory markers that I'm going to talk about in a little bit when we put up the slides. And then I really look at all of those things in the context of that person's health, who they are, their genetics, all of the pieces of the puzzle that I have. And then I try to set a course for them of how we're going to modify their cardiovascular risk so that we can keep them out of the danger zone.
Beautiful. And, over time, I mean, how is your perspective on how to do that evolved, given all of this like extracurricular education you've had in dementia, as you mentioned, type 2 diabetes, when you've been on the forum before, and we did that event in Davis, I know that you've done a lot of work with environmental toxins. I mean, obviously that's what it takes to be a functional medicine doctor, but ultimately, I guess, how has your viewpoint on heart health particularly evolved over the last 14 years of practice?
Well, I think, in like many people who practice functional medicine, the more you know, the less you realize you know. And so it gets more and more and more complicated. But really, the message that I wanted to bring to our discussion tonight and to share with people is that at its core, it's really pretty straightforward what we need to be doing to help people prevent heart attack and stroke. It doesn't have to be complicated at the level that it can be. Of course, that helps for the people that are really difficult challenges. But for the majority of people, this is accessible to any provider who has an interest in doing it.
Great. Well, let's jump into it.
Let's do it. All right. Nope, wait, that's not it. Here we go. Okay. So this is really the message that I want to bring, and that is that it's absolutely possible for us to say goodbye to cardiovascular disease. So let's think about what really is going to kill us. I know for women, many of us fear breast cancer as being our greatest risk of dying. But the reality is, while it's terrible and breast cancer kills about 40,000 women a year, cardiovascular disease kills about 500,000 people in the US every year. It takes 65% of men and half of women. This is really where our greatest risk lies. And it's probably one of the things that we give a lot of lip service to, but we really don't give the attention that it needs. And you'll see how that unfolds. So I think part of the reason that cardiovascular disease is our biggest death risk is really at its core because of these 7 deadly myths that people believe. The first is that cholesterol causes all heart attacks. And so that has been perpetuated, as we all are well aware, for the better part of the last 30 years. And while I'm not saying that lipids aren't important in cardiovascular disease and progression, the reality is half of all heart attacks occur in people who have normal or at goal cholesterol levels. So this is not the it thing. And if this is our singular focus, we're going to miss a lot of people and a lot of opportunities. Then the next myth is that a stress test can help determine your risk. So when we look at what a stress test is capable of identifying, it really can identify an obstruction, an arterial obstruction that's about 70% or greater. But 86% of heart attacks are from plaque blockage or occur in people with plaque blockage that is less than 70%. So you can see that we're missing the lion's share of people who are at risk for cardiovascular disease if we rely on tests such as the stress test to tell us who is at risk. This test really has the capacity to tell us who is already at risk, but not who is at risk. And that's what we need to be able to figure out to save lives. The next myth is that normal blood sugar is normal. Now, I know those of us that are probably here listening to this and a part of the functional forum, these are all things that we know. But what I want you to do is I want you to take this information and think about how you can expand the knowledge of the people you know and care about and the general public, because these are the messages that we need to get through. So in the course of the last, James was kind, 14 years in functional medicine, but almost 30 years of practice. So in the course of the last several decades, I've watched the benchmark for normal blood sugar change time and time again. And so the misconception now is that normal blood sugar, something that falls in what we've designated as the normal range, is normal, but it's not. It's not at all normal. And what we now know is that abnormal fasting blood sugar follows about 20 years, 2 decades of avoidable damage. So this is really the metabolic equivalent of letting the house burn down and then calling the fire department. We are letting this damage occur, and we need to get that message across. The next is that low risk measures equal low risk. So we talked about the stress test, but we also have things like the Framingham cardiovascular risk calculator or the Reynolds risk calculator. And while they can help us identify people who have higher risk, they have an extremely poor negative predictive value of like 83%. So the majority of people aren't being identified as being at risk. The American College of Cardiology said this: using current guidelines, 88% of heart attack victims would have been deemed low to moderate risk if they were evaluated the day before they died. And this is a picture of Tim Russert, who had his risk evaluation and had his treadmill test, and then unfortunately died of an MI about 2 months later. So we are missing the people that we can be saving. The next myth is the myth of mild disease. How many times have you gotten back a carotid ultrasound or some other imaging modality where in the comments it says that they were noted to have mild vascular disease or carotid with, X amount of obstruction, and then the summary is that it's mild disease? Here's the bottom line. It's like a pregnancy test. You either have it or you don't. You either are or you aren't. If you are making plaque, then you are at risk for having an event. It doesn't have to do with the obstruction, or doesn't completely have to do with the obstruction. Only about 15% of events occur because of progressive clogging of the pipes. Then the next myth is that we are all the same. Now, those of us in this world know that this is far from the truth, but this is what the general population experiences. And we know that there are variations in our genetics. For example, if you have high Lp(a), your risk is completely different than if you don't have that. Or if you have a KIF6 mutation, you are not going to respond to a statin alone. So we have all of these things that can help us figure out who is at greater risk, who is at lesser risk, and what types of things are going to put that person at risk. Therein lies our approach with our personalized medicine. And then the last myth is that the standard of care equals optimal care. And in fact, back in 2009, JAMA issued this cautionary statement, and it was that clinicians need to exercise caution when considering the majority of guidelines for cardiovascular treatment. We cannot allow our patients, our loved ones, to rely on the standard of care thinking that they are going to get optimal outcomes. So here's the message that I think that we should be giving. I think we need to help our patients understand that plaque, any arterial plaque, thin, small, moderate, great, any plaque is like having dynamite stored in the wall of the artery. And that dynamite is safe if it's stored in a nice, cool bunker. But we all know if that plaque ruptures, that we develop a clot that can occlude the artery, and the clot is the killer. So what we need people to understand is that it's inflammation that triggers this event. The plaque is the dynamite and the inflammation is the detonator. It's a very simple message that people can understand. And as we know, there are all manner of things that are telling us about inflammation going on in the body that we don't even necessarily have to do lab work to know that these things are a problem. We talked about blood sugar regulation. We've got gum disease, arthritis, migraine, sleep apnea, restless legs, which is neural inflammation. So we have a lot of ways of knowing that inflammation is happening, even if we don't have the ability to do labs. Then the last piece of the critical puzzle is extinguishing the fire, helping people identify what's going on, and then helping them learn how to extinguish the fire, because without the fire, we don't have the explosion. So here are some of the things that we look at in our cardiovascular wellness program. Myeloperoxidase and LPPLA2, which are looking for inflammation specifically in the vascular wall. We look at the HSCRP for systemic inflammation, the microalbumin creatinine ratio, looking for evidence of that leaky endothelium as we see protein leak into the urine, F2 isoprostanes and oxidized LDL, looking for high levels of oxidative stress, and then ADMA or asymmetric dimethylarginine, which is a surrogate marker for our endothelial health and the capacity to produce nitric oxide, which are both really important roles of the endothelium and what we'll talk about later, the endothelial glycocalyx. This is what it looks like when we're explaining to people what's happening in that progression. I know I don't need to explain it to you, but this is just a way of making this message accessible to more people. And then periodontal disease. How many people are offered a periodontal pathogen assessment as part of their cardiovascular risk stratification? But there was a study done quite a few years ago at Harvard where they aspirated clot in the cath lab from people who had intra-arterial coronary clot, from people who had MIs, acute MIs, and were taken to the cath lab. And they found 70% of those clots contained periodontal pathogens. So this is a really important piece to our root cause puzzle. So here's some of the results that we've been able to accomplish, because we don't just want to stabilize things, right? We want, in our world, we want to reverse things, and we love achieving plaque regression. So this was a patient of mine, a 50-year-old world-class jiu-jitsu competitor who was diagnosed with hyperlipidemia back in 2011. And he had accomplished in our work a total plaque regression since 2016 of more than 70%. And actually 57% of that was in 1 year. And that was when we started paying attention to his endothelial glycocalyx. This is another example. There's many examples like this, but these were, I thought, particularly impactful. This is a patient, a 70-year-old with hypertension, hyperlipidemia, prediabetes. And you can see here, these are images from his CIMT, his carotid CIMT ultrasound study. And you can see we had all these areas of plaque here, and then we had only one remaining area of visible plaque. And his total plaque reduction was about 76%. That's a lot of regression. So here's what happens when you pay attention to the red flags in someone's history and in their chronic medical conditions, when you take into account some of their genetic information, if you have that available, when you look for disease present, do they have plaque or not? And then when you look for and address the root causes of inflammation. So in our practice, that has meant 0 MIs over 12 years in any of our patients over 50. And half of the people in that statistic are people over age 65. So yeah, it is a statistic that we're pretty proud of.
It's so awesome. Well, I'm glad to share that. And thank you for sharing that so clearly. I guess one of the things that I'd love to ask you, and I kind of know the answer, but I want you to share it with everyone else is, obviously there's a lot of practitioners, cardiologists, primary care people around the country giving a lot of good information out there. But like information doesn't equal, participation. And I guess maybe just share, like, what are some of the things that you found in your clinic which are sort of activating people into really participating in the way that you'd like them to? And what ways have you found to engage people into that information in such a way that they go home and get into it?
Yeah, so I think part of it is telling that story. It's one thing to be told there's a bunch of labs that we need to look at and we need to monitor them and we need to adjust them. That's kind of, our cerebral world, but people understand stories. And that's why I like having that story to tell. And then we can watch over time as their efforts cause improvement, or we see them fall off the wagon and we see their numbers get worse. So it starts to become really real that they directly have control and an impact on their potential risk.
Beautiful. Awesome. And I'd also just give a shout out to like the educational material. I mean, obviously, I think, some of the content that you've shared here, like, the simple ways of describing things, the visual assets, like these are all things that really help it to land. And obviously, I've had a chance to work with your like dietitians and health coaches too. So I understand that like it's a team effort, and
Absolutely.
that makes a big impact. So, well, thank you. I guess before I share I'm going to share a little interview that I did with Mark Houston. Has Mark been has he impacted your career over the last couple decades?
Mark is one of my idols. He's just amazing. His textbook is literally a how-to guide for how to help people avoid these outcomes. And I have incorporated so much of what I have learned from him into what I do now.
Awesome. Well, let's do that. So, Mark was hoping to be here tonight, but he wasn't able to be here at exactly this time. So I actually recorded a short interview with him where we talk about a little bit about what he's got going on in his practice. One of the reasons why I wanted to start with Dr. Burke is because I feel like Dr. Burke's practice is really something that every person who's watching this could replicate, given enough time, energy, and effort, because ultimately, it is, it's a model functional medicine practice, I would say. Dr. Houston, on the other hand, has built a very, exciting practice of the future. And so we talked a little bit about it. So I'm just going to share this interview that I did with him a few days ago. So a warm welcome to the Functional Forum for the first time, Dr. Mark Houston. Welcome, Doctor.
Thank you so much for having me, James.
Yeah, I just want to first acknowledge, having been in and around the space now for 15 years plus, I know that so many doctors and practitioners out in the community have come in to functional medicine through the theme of, your focus in cardiology, and certainly tweaked so much interest in a broader practitioner community from the combination of your education, credibility, and obviously the heart health catastrophe that we're sort of living through over the last, couple decades, and seemingly getting worse all the time. So I guess maybe just because you haven't been on the show before, can you share a little bit of your story of, what got you into practicing like this, and what's led you to end up being a leading educator in the sort of functional cardiology world?
Absolutely, be my pleasure. I practice in Nashville, Tennessee, and I started the Hypertension and Vascular Institute in 1995. And that's when we started developing an integrative cardiology practice that is now worldwide. We have patients who fly into Nashville from all over the world for a cardiovascular consultation for 2 to 3 days, and try to get them on a different preventive course in cardiology, because most of the typical treatments that are not just in the US, but other countries don't provide all the necessary diagnostic testing and treatments for prevention that we integrate. So we include everything in nutrition, nutraceutical supplements, lifestyle changes, and pharmacologic therapy if necessary. I started this primarily because there was a gap in cardiovascular medicine. And I realized that if we continued on this pathway, that cardiovascular disease was not going to get any better. And it's continuing to get worse, as you know, in all countries. But what's really scary, it's moving back now to younger populations. Even in the teenage years, we're seeing diabetes and dyslipidemia and hypertension, and now earlier coronary heart disease and heart attacks in 30-year-olds. So what we're trying to do is take this entire process to a new level where we can move people back to a different starting point and try to prevent them from having a entity of MI and strokes and heart failure.
Yeah. I mean, do you think the factors that underlie heart disease are getting worse in society, or do you see that there's like a transgenerational effect on humans being born, that they just don't have the same amount of resilience to the existing environmental factors?
I think it's a combination of genetics and environment. There's clearly younger patients getting more risk factors. The risk factors haven't really changed, but the real point I'd like to make to your audience is that the top 5 risk factors, which everybody talks about, hypertension, dyslipidemia, obesity, smoking, and so forth, are only 5 of the 400. And if you ignore the others, then you're not going to get a good result. And that's what we're trying to do, is broaden the perspective of risk factors combined with your genetics and try to do what's called gene expression to turn off those problems that get really severe in older life.
Yeah. Can you give your thoughts on preventive cardiology? Because that has become sort of a buzzword, but I guess I'd love to just get your thoughts on it, because we're obviously not preventing a lot of cardiovascular events, or we're not getting better at it.
I think the problem in the term preventive cardiology is that it hasn't kept up with the science. We do things at the Hypertension Institute that are not done even in some of the major referral centers across the country. And I won't mention any names, but I'm talking about some big names. And what we find is that people show up in our institute having never had these tests done, and we find things that were totally missed, or they're being mistreated. And so what we're trying to do is step back to the equivalent of a teenager looking at tests that identify by decades before they get a heart attack things like endothelial dysfunction, glycocalyx dysfunction, arterial compliance issues. And we have enormous amounts of diagnostic equipment in the Institute where I can identify these things very early, do their appropriate genetic testing, and treat them aggressively and early before they get into a problem with a clinical cardiovascular disease.
Yeah. So do you have, like, let's say you do this whole battery of tests, do you end up bringing that together into some sort of comprehensive score so that people can kind of see where they are on the spectrum of cardiovascular risk and disease?
Yes, absolutely. We have a very complex risk scoring system where I can tell you within 5 years of your actual vascular age, your future risk of having an MI or coronary heart disease. We can do that over 5 years, 10 years, 20 years. We can look at risk for a cardiovascular event. You can even look at risk for cardiovascular death. And once we have all that, there's a very comprehensive treatment program. And if people do it, we've shown in the last 20 years that we can actually prevent and maybe in some cases reverse coronary artery calcium and coronary artery plaque and move them back to a low risk category.
Beautiful. Well, let's dive into some of the details there, because this session was actually focused in on the endothelium, and I know that that's an area of particular interest to you. When did you sort of discover that this was a sort of a critical nature in the outcomes, and how have you built your diagnostic and therapeutics around the importance of the endothelium?
We started looking at early risk factors, ED, and glycocalyx dysfunction probably 25 years ago. And as the technology caught up with the theory, there were different machines that came out that allowed us to actually measure these accurately. So we can measure endothelial dysfunction now with machines like the EndoPat. We can measure glycocalyx dysfunction. We can look at arterial compliance issues. There's a lot of things we can measure. And once we have that data, we know exactly what your risks are for having a future event. And then we develop treatments around each of those different testing procedures.
Beautiful. And if you were to take a step back, I mean, how much of your work would you say is, like, if we look at functional medicine, it's sort of half lifestyle medicine, half precision medicine. If you look at the outcomes that you generate, would you say, like, what part of your work are the outcomes being generated by the lifestyle medicine component, i.e. getting people to do different things in their everyday, versus the precision medicine, looking in at some very specific test and making, let's say, a supplement or a drug prescription based on that information?
Yeah, we do what's called personalized and precision integrative cardiovascular medicine. Now, what I mean by that is that every patient is different. And we look at everything about that one patient. It's not a statistical analysis of the world's population. It's what do you have wrong with you? What are your genetics? What are your risk factors? What are other environmental factors and lifestyle that have to do only with you? And by doing that, the program is extremely precise and it's comprehensive. It's everything you just mentioned. It's lifestyle, it's nutrition, it's supplements, it's drugs, it's everything you can think of. And only by doing that can we actually start to prevent and even reverse coronary heart disease.
So when you track your outcomes versus the cardiologist down the road, what sort of difference are you making, in a short period and a longer period, and how, in all the time, how have you best been able to quantify or qualify the outcomes?
Outcomes are dramatic. They occur early, and then we keep them out of trouble. I'll give you just an example of how I know that. We've been tracking people, as I said, for 10, 15, 20 years, and we've looked at coronary calcium scores that are dropping. We've looked at people who come back in for coronary arteriograms. We're seeing plaque regression. In the literature, you'll not find that information. People say you can't do it. Well, I can tell you, we can do it, and we are doing it. So I know that's working. And then we look at outcomes. Are we actually preventing heart attacks and coronary heart disease and other complications? The practice that we have the lowest hospitalization rates of anyone in our network. And that network is huge. It not only includes the groups in Nashville, but it also includes big insurance companies. Again, I won't mention names, but we're talking millions of patients who come in for traditional testing, and they compare each of us to our hospitalization rate, to our emergency room visits, to our outcomes. And every time they come in analysis on the Hypertension Institute, what we do, we're always the tops.
So how have you thought about scaling these efforts? Because I know obviously you've been an educator through A4M and IFM over the years, and there's lots of different doctors out there that I know personally that have sort of like a mini Mark Houston practice. They don't have all the same gadgets, but they're sort of doing a similar brand of care because you've educated them. Obviously, there's a lot that goes into, building your system. I mean, we're seeing a time in medicine now where the kind of outcomes that you're talking, reduction in hospitalizations, getting people off medication, improving health, could actually be valued, right? In a value-based contract by an employer or an ACO or, an insurance company. Do you ever give thought to what it would take this from becoming sort of like a niche functional medicine practice into a cardiological standard of care?
Well, we're trying to do that, James. I've trained several hundred traditional cardiologists in A4M over the last 15 or 20 years. And most of them have left their traditional cardiology practice where they were doing arteriograms and all that, and now doing a functional or integrated cardiology program. And there's I'd say about 75 or 100 of those across the country now that I've trained at A4M. So we're expanding the niche program, and then what's going to be seen is a large groundswell of people, not only in my practice, but in their practice, who are achieving better outcomes, but also reducing healthcare costs. And once insurance companies start analyzing what we're doing compared to traditional approaches, then I think they're going to probably change their entire approach to cardiology and pay for more prevention rather than intervention.
Yeah, I hope for that too. Well, I'd love to stay in contact about that. Well, look, Doc, thank you so much for being part of the Functional Forum, in this episode. Thank you so much for being part of the forum. Really appreciate, you leading the charge. And I hope that through our efforts and obviously the other efforts of, going back of your efforts of 25 years, we can find a way to have this kind of standard of care available in every city in the country and then eventually down the world. And anything we can do to support, your delivery and the standard of care would be a pleasure. So thanks for being part of the forum.
Oh, it's been my pleasure. James, right before we go, let me just mention there's a couple of
So a warm welcome to the function. All right, so that was a few days ago. And for those of you who are watching very closely, you'll see that my mountain man beard has disappeared and now I have a less aggressive beard. All right, we're going to talk about the endothelium and the glycocalyx. That was something that was mentioned as critical there by Dr. Houston as why his practice was able to achieve the outcomes. And so I'm super excited to have Dr. Mike Twyman here, who is a cardiologist and loves talking about these two things. And grateful to have you, I think for the first time on the forum, Dr. Twyman. Thanks for being here.
Thank you for the opportunity tonight.
Well, let's start with here. I've got a picture for you. So tell us what's going on there and why this is important to really understanding heart health and particularly these two topics that Mark mentioned there.
Sure, and thank you for the graphic. This is excellent. So this is a picture of a artery in cross section. So think of it like a garden hose chopped in half. And where the white section is, there's the lumen. That's where the blood components are floating. But the little scraggly black lines, that's the endothelial glycocalyx, or the EGX for short. This is something that honestly I didn't know much about until about a year or two ago. I'd heard about the endothelium years ago. I'm pretty sure it was Dr. Mark Houston that taught me about it back in 2014. But this is stuff I did not learn in my traditional cardiovascular training. I finished my fellowship back in 2012. But the glycocalyx is the protective coating of the endothelium, which I think a lot of us do know about. And that underlying endothelium is only one cell thick. That's the protective coating lining the artery walls that one of its major components is it releases nitric oxide. And that nitric oxide is very important to dilating arteries, so that improves flow, keeps blood pressure down. But nitric oxide is protective in that it prevents things from sticking to the artery wall. But what's protecting the endothelium? It's this glycocalyx. It's this microscopically thin coating. Think of it almost as like cotton candy consistency. It has these different proteoglycans, glycoproteins. These things are highly sulfated. They're highly negatively charged. And when things are negatively charged, they repel other negatively charged things. So I think of the glycocalyx as a protective coating that it's very easy to damage, but there's many things you can do to help repair it. So this is the first sign that there's something wrong with your arteries is when you start damaging the glycocalyx.
How is it that a cardiologist doesn't get this in their training, given that this is obviously like critical? And Mark was saying he's been knowing about this for that long. Is it just that this is new science, or is it just that it just wasn't deemed to be that important?
I don't think that it wasn't deemed to be important, but it's just that the glycocalyx has only been able to visualize for the past few years.
Got it.
The technology is, becoming where it's almost going to be capable to do this in the office, that you could assess people's endothelial glycocalyx function. It's not there yet, but it may be coming in our lifetimes in short order. Right now, you still need some fancy microscopes to be able to look at this in presentation. But the theory has been around for many, many years. It's just getting the information out there has been the challenge, I think.
Yeah. Okay, great. So tell us a little bit about, your practice. I mean, you're obviously, trained now in functional medicine, but as a cardiologist, what is the sort of major groups of patients that you're seeing, and what is your sort of, I guess, central thesis? Do you resonate with what Mark and Dr. Burke shared here today? Are there similarities, or are you a little bit more like, focused because of your background and training?
No, I think we're very much aligned. Dr. Houston's a great mentor, and I've known Dr. Burke, at least virtually through these kind of conferences for the past year or two. But yeah, that's my focus. I was trained as an invasive cardiologist. I did thousands of coronary angiograms in my career. I treated hundreds, if not thousands, of heart attacks, and it was very satisfying to help people. But I always felt a little bit dissatisfied that why did the person wait this long? Why did we have to kind of rescue them right at the end? And so I knew there was more to what we were doing. Dr. Houston mentioned that, many of these people's blood pressure were well controlled, or their quote cholesterol was optimized, and they didn't smoke, and they weren't obese, and they weren't diabetic. why did they keep having events? It was just somewhat of a mystery, but you had to kind of put your head down and go see the next patient because you saw 20, 30, 40 patients a day. You just didn't have time to really research that question. And so then I got curious and kind of like unplugged from the matrix back in 2014, started doing more of the functional medicine training. A lot of it was with Dr. Mark Houston, and just really started thinking about, oh, this endothelium thing is really the root cause. If we help support the endothelium, these events are not likely to happen as much. And then now we know a little bit more that what protects endothelium is this glycocalyx. So in 2019, I kind of revamped my practice. I left traditional cardiology. I no longer round at the hospitals, and I only work with outpatients, mostly looking at endothelial health.
That's great. So, you know, for practitioners who'd like to bring like some V1 version of this into their practice, what would you say are sort of like the starting points to assess endothelial function today, and then, you know, monitor the progress of whatever interventions you recommend over time?
Sure. So the things that require not a lot of capital front is, you know, what is the person's blood pressure? You know, that's a good marker of endothelial function. You know, if their systolic blood pressure is greater than 120 or 80 millimeters of mercury, they very likely have some component of endothelial dysfunction. And there are fancier devices that can actually measure your central aortic blood pressure, which is a better marker of end organ damage to your heart arteries, your coronary arteries, your carotid arteries, or your renal arteries. But just a brachial blood pressure is a rough estimate for things. There are many companies that make salivary nitric oxide test strips. They're not perfect, but you know, they're kind of like litmus paper. If they're bright red, you're probably making good amounts of salivary nitric oxide. If they're white, then you got to kind of go look into why they're not doing it. Maybe they have a dysfunctional oral microbiome and they're using, you know, antiseptic mouthwash. Maybe they're on an acid blocking medication and they're not able to break down proteins or make enzymes efficiently. A lot of times it's removing the things that are causing the problem. That's definitely stuff I learned in functional integrative medicine. It's not give them more things, it's withdraw things that are damaging the endothelium. So those are kind of the quote free things. You know, we're all trained in, you know, looking at a lot of these advanced labs, and Dr. Burke put up an excellent slide deck on, you know, all the inflammatory markers. And those are things I routinely check in my patients, you know, the high sensitivity CRPs, the myeloperoxidase, the LP-PLA2, the ADMA, SDMA, uric acid, homocysteine. Those are all kind of things that have an effect on nitric oxide, because if you have high oxidative stress or high inflammation, you're not likely to make, you know, optimal levels of nitric oxide. So that's kind of the cheaper free things. And then, you know, the things that are not, you know, terribly capital intensive, there's a device called the Max Pulse. It looks at pulse wave velocity. You know, your arteries should be like an accordion. They should be very expandable. You know, the Max Pulse is graded 1 through 7. 1 and 2 are normal or good. 6 and 7, your arteries are like a lead pipe. If your arteries are really stiff, often it's either they're heavily scarred with plaque, or they just really lack the ability to make nitric oxide to get the smooth muscle in the artery wall to relax. So the Max Pulse looks like a pulse oximeter, but instead of measuring your oxygen saturation, it's measuring the elasticity of the blood vessels. So if you have elastic arteries, you're likely making good nitric oxide. So that's kind of a starting point that almost anybody could do. And then Dr. Mark Houston did mention there's a device called the Endopat. I have it in my office. It's a non-invasive 15-minute test that basically is a stress test for your endothelium. Takes 15 minutes and tells you how much can your arteries dilate with a vessel stressor. The vessel stressor is implemented by putting a blood pressure cuff on the person, pumping it up over their systolic blood pressure, temporarily cutting off the blood flow to that arm. And then after 5 minutes, when you open up the stopcock and blood rushes back in, there's reactive hyperemia. Essentially, that blood rushes back in, it transduces the endothelial glycocalyx, tickles it, and that transduction gets sent to the endothelium. The endothelium's like, oh, here comes this big slug of blood, releases nitric oxide, the artery dilates, and the blood rushes back down into your hand. And so you can measure at the Endopat the percentage of how much the arteries dilate. They should roughly double in size with this stressor, but more optimal is a tripling or quadrupling in size. So those are the starting points for endothelial function. And later, you know, there's things that you can look at for plaque, you know, carotid intimal medial thickness test, calcium scores. There's a special type of CT angiogram that a lot of people are doing now. Those are later staging findings, but it's always worthwhile to start looking upstream first, because it always starts with endothelial glycocalyx and endothelial dysfunction.
Absolutely. Yeah, look, I want to, I'm grateful you shared that. And I guess, Dr. Burke, maybe just to from what you've seen today, I mean, it seems like there is a new standard of care emerging in heart health, and it can't happen quickly enough given how bad the situation is. You know, if you look at all the interventions that we're talking about, you know, I guess you know, like, I guess what I'm trying to get to is, you know, obviously, like, years before, decades before any of this endothelium understanding was there, like Dean Ornish was doing his thing and getting lifestyle changes and putting people in groups and connecting people and showing that you could reverse some heart disease. Obviously, you know, what we've talked about here today is built on that, but also understanding that there's, you know, there's more specific information you can get to treat the individual. You know, if you put all those pieces together, it seems like the standard of care for heart disease is pretty far off, you know, what we need in order to prevent and reverse heart disease.
Mm-hmm. Yeah, I would absolutely agree. I think, you know, we've focused so much on the amazing life-saving work that people like you, Dr. Twyman, have been doing all these years in rescuing people, but we're letting them get so far down the road before we're doing anything for them. And that's really where this paradigm shift comes in.
Yeah. And would you say, like, you know, when you have people come to your office, Dr. Burke, you know, I know you've had doctors come in who were just, you know, conventionally trained, and now you start to bring them in. Is this an area where you think that it's sort of like an easeful entry? Because, I mean, I think, I don't know, it seems less complicated than like some of the autoimmune stuff that we get into in functional medicine.
Yeah, for sure it is. I think that this is a really great place to begin. It's really where I started bringing a lot more of functional medicine into my practice. Bioidentical hormones was what I was doing first, and then this really was the next step in. And I think, you know, knowing what we know about the statistics of the prevalence and the incidence of cardiovascular events, this is really a high value target. And as you've seen, as the three of us have talked, there's such a wide variety of things that we can employ to have an impact on this. But there's so much that you can accomplish, even if you can't afford to bring in the fancy bells and whistles equipment. And so I think, you know, that's really the message that I wanted to get across tonight, is that anyone can do this and have a huge impact on people's health.
Do you think the lipid versus inflammation conversation is a lot further ahead than it used to be? Because I see that seems to be like the biggest sticking point, right? Historical cardiology, very lipid focused, functional medicine cardiology, very inflammation focused. That seems to be breaking into the mainstream a little bit. When I see on Twitter, I see more and more cardiologists talking about inflammation. What do you think about that, Dr. Twyman? Do you still maintain some online places where you talk to other cardiologists who haven't made the jump? And do you see that that's making its way in?
I think I've just kind of bypassed them. I don't really interact on that aspect, but I'm always happy to educate them if they're interested in what I'm doing. I think I'm 10 to 20 years into the future, essentially. But yes, you know, traditional cardiology still seems to be very lipid centric. And, you know, Dr. Burke mentioned earlier, you know, they're important, but is it as important as having a healthy endothelium glycocalyx? Probably not. If you have a healthy glycocalyx, again, it's highly negatively charged. Your lipoproteins are negatively charged. Negative repels negative. So I tend to think of it as like, if you have a healthy glycocalyx, it's so much less likely these lipoproteins are going to start sticking to your endothelium, getting retained in the intima, causing swelling, starting these, you know, foam cells building up. So I'm more of a glycocalyx centric person at this point. But I kind of put it into three buckets. Yes, I'm always looking at the inflammatory markers. Yes, I'm always looking at the lipoproteins, but that third bucket is really this endothelial health bucket that people need to start really focusing on.
Great. Well, look, I want to change track here for the last 10 minutes, because obviously, you know, it's February 2023. It's not 2019, where we could have had basically everything up until now. We could have done this in 2019. Obviously, the focus on heart health in the last year and a half has been, you know, pretty significant because of a number of things. I want to share a very short clip, actually, that I got off Twitter this week, which is from Paul Offit. So Paul Offit is, you know, obviously a leading vaccinologist, infectious disease expert. And I saw an interview with him, but there was just this one clip that I'd love to share to I guess, trigger a little bit of a conversation here for the rest of the session here about that, because I want to talk a little bit about myocarditis. So let's just watch this, and hopefully everyone will be able to hear this.
There certainly is a causal link between vaccination and myocarditis and pericarditis, no doubt about it. It's unclear why. I mean, it may be, as was actually noticed in 2020, that SARS-CoV-2 virus, the spike protein, mimics one of the proteins on heart muscle cells, specifically the heavy chain of actin. So if that's true, then while you're making an immune response to the SARS-CoV-2 spike protein, you're also inadvertently making an immune response to your own heart muscle.
All right, so now we're getting into, I guess, some of the, like, that's some like functional medicine stuff there, right? There's some antibodies and so forth. Dr. Burke, what do you think of that I mean, it's unlikely that kind of, this is new information, right? To be able to say, hey, there is a causal link that hasn't really been talked about, but here we are in February 2023. What are your thoughts on that?
Right. So, I mean, we know that the risk of myocarditis and pericarditis is higher with the vaccines, and it's in the package insert. So it is known information. The mechanisms, like he speculated, we don't fully know. And we do also see myocarditis in patients, in some people who have been infected with COVID. And so it does look like the spike protein is a vascular toxin at some level. And probably a lot of it is through the endothelium and the effect that it has on the endothelium. And I know, Mark, you had a lot of thoughts on that when we were chatting earlier.
Right. And I think that's even back in 2020, I think it was Peter Libby had put an article out that, COVID is an endothelial dysfunction disorder. It was thought that the spike proteins, either natively acquired or through vaccines, damage that endothelial glycocalyx coating, that cotton candy consistency coating. And so if the glycocalyx gets damaged, there's going to be more oxidative stress. There's going to be more clotting. There's going to be more inflammation. So it's back to Dr. Mark Houston's, 3 finite responses for the arteries: oxidative stress, inflammation, autoimmune dysregulation. So infinite insults, just one of those insults can be the spike protein, no matter how it gets into your system.
So Dr. Burke, how do you intend on keeping your unblemished record here then?
Oh, I know. I feel like the hammer's going to fall soon, huh? All I can say is that we do aggressively manage the endothelium and the endothelial glycocalyx. And I think that, we also had 0 COVID hospitalizations and 0 COVID deaths in our patient population. And you saw, we have a lot of people that are over 50, over 65, and that have comorbidities. So I think that the things that we do in functional medicine do seem to have a positive impact on changing the way, whether it's changing the way the immune system responds in the face of either of those things, or if it has to do with just having the system more equipped to handle the damage. I don't know what the underlying mechanisms are, but clearly there is an advantage of paying attention to all of these things.
Does that sound about right to you, Dr. Twyman? You're obviously you've been in as a cardiologist for this long. Has myocarditis been a thing before? Is this very new? And have you had to go back to the textbooks to really understand what's going on?
No, not necessarily. But I would say that I've not seen that many cases in my current practice, because my practice is a little bit more niche, where I'm more focused on the prevention side of things. So I'm not rounding in hospitals anymore where the myocarditis cases really were showing up. But no, in my conventional training, I saw cases of fulminant myocarditis a few times. It's usually younger people with, really bad infections. And, they, if they survive, but they ultimately sometimes need some very heroic care to pull them off the ledge. But myocarditis, just inflammation of the heart muscles. So, if you can figure out what's causing it, you can then support the body's ability to try to fight the infection or, cool down the inflammation if possible.
Yeah, absolutely. I guess, one of the things that concerns me, I guess, from a sort of being an economist point of view, something that I asked Mark Houston there is do you see that the problem is just the conditions in the environment are getting worse? And Dr. Burke, some of your presentations about, the state of the environment could say that. But ultimately, it could also be like, is there some sort of like transgenerational epigenetic effect where our resilience is getting lower? Like, is the quality of the glycocalyx and the endothelium going down, generation to generation, and causing, less, I guess, less reserve, right? Whatever you might call that, heart health reserve in the tank. And I guess one of my concerns is that, obviously one of the things that happened with the vaccine is we didn't really have time to understand what are the implications 1 year, 2 year, 3 year, 4 year, 5 year down the road. And as you said, Dr. Twyman, like if there's insult onto insult onto insult, that there's at least a chance that by turning the body into a spike protein creating mechanism, that may, and there is toxicity there, we may see, a body that's creating its own insults. And I don't know if that's just I guess my way of thinking about it. How do we best prepare for that possible eventuality?
I think it's what we've been chatting about. It's, test, don't guess. If you look at your artery elasticity, you look at your nitric oxide levels, you look at a lot of these inflammatory markers, if your body's handled this or there's still a raging fire going on in your system that you need to address. So, if you've been on the front lines of trying to help people not have heart attacks for 10 years, yes, this was a challenge, but it's mostly an endothelial function issue. And if you know how to do that, which isn't that terribly hard, there's many lifestyle things that are free to do. There's obviously different nutraceuticals that can help support nitric oxide. There's ones coming online that help support the endothelial glycocalyx. If you do these things, you get more oxygen nutrients into the tissues, get the toxins away, things tend to improve.
Absolutely. Dr. Burke, anything you want to add to that?
No, I agree completely. I think it's just, it's all of those things together, right? It's always about the exposome. It's all of the different insults that our bodies have to deal with, manage, and dispense with if they can. And if it's something that we have a hard time getting rid of, then we need to be the ones paying attention to that and helping the body to offload it. But much of it, as Dr. Twyman said, is about getting rid of things that are creating damage.
Yeah, absolutely. Well, good. Well, look, I want to, end with a couple of thoughts here. So first off, we have a podcast coming up in a couple of weeks that I've already recorded with Dr. Nathan Bryan talking about all things nitric oxide. So you've mentioned a few times here, and I would highly recommend that because it does seem that, obviously there was a Nobel Prize awarded for the understanding of nitric oxide. And Dr. Bryan actually had some pretty clear thoughts on nitric oxide and the spike protein, which I think was very instructive. So I would highly recommend that if you're not a regular listener to the podcast, you check out that. I think it's coming out in a couple of weeks. This is going to be part of our focus here at the Functional Forum for the next few months for a few reasons. One is that, this is mission critical information. I personally believe that more than ever, the functional medicine community is showcasing how we need to do this right. And because, even what Dr. Office said, there are some like sort of potential autoimmune things in here. This is well understood by our community too, right? These are all things that there is expertise on. These are all things that, that people in our community have been, diligently working on for decades. And so I really think this is our time to shine as a community. And so I want to just thank both of you for your participation and really doing what you're doing on the front lines every day. I mean, Dr. Burke, obviously, I'm super grateful to you as my physician, but Dr. Twyman, leading the way for cardiologists and building the practice that you have. Obviously, as Dr. Houston shared as well, like there's a network forming of where you can get this evolved standard of care. And, over time, I think we'll just start to see that the data will show that this is the way that we should be doing, heart disease care. And I'm super sure, I'm very sure that this is coming sooner rather than later as things get worse, right? And that's one of the things that we've been sharing in the newsletter recently is just all the signs that things are getting a little bit worse around this. Having really made some progress with heart disease, I would say, for years, it is going back in the wrong direction. So just before we leave here, I would share one more thing, which is that Dr. Twyman will be a speaker. We will have a focus on cardiometabolic health here. So in 4 weeks' time, we'll be back for another functional forum. We've got Dr. Mimi Guarneri, who many of you know is a leader in functional medicine, and she gave an incredible interview. We're hoping to have Dr. Regina Drews here. As you heard Dr. Houston mention there, she's a cardiologist, but she works at an organization called ChenMed. And ChenMed is a leading primary care entity around the country doing value-based primary care. And she's bringing functional medicine cardiology to that organization. Should be very, very interesting. And I'll be with Dr. Twyman at this upcoming PLMI event. It's a PLMI event. Dr. Bland came up with the name because only Dr. Bland comes up with this kind of name. Cardiometabolic function, the intersection among neurology, endocrinology, and immunology. This is really the cutting edge of where healthcare is going. This time last year, we had the first PLMI back, and it was all on all things long COVID. There's obviously crossover into it. So if you're interested in hanging out with Dr. Twyman, myself, and a number of other leading educators, it's going to be April 21st and 22nd in the Chicagoland area. We'll be coming there with the Functional Forum cameras to make an episode. So we're excited about that. So please join us. Thank you very much, Dr. Burke, Dr. Twyman, Dr. Mark Houston, for being part of the Functional Forum. Please get in touch with us if you have questions about what you've heard tonight. You'd like to hear us cover more things on future functional forums. As I mentioned, that podcast with Dr. Brian, we have other great podcasts coming up on topics like non-acute fatty liver disease, another area where I think that functional medicine is poised to lead. We'd love to have you. So thanks so much for tuning in. This is the Functional Forum, and we'll see